over. Good afternoon, everybody, and welcome. My name is Philandra Costello. I am the lead nurse for the Central and South Genomics Medicine Service Alliance, and I'm going to be hosting today's webinar, which is Protecting Hearts Across Generations, Genomic Medicine in Cardiology. Thank you so much for joining us. We're really pleased to have you with us. So before we get started, I just wanted to ask if you could take a moment to complete the pre-session survey if you haven't done so already. I have popped a link there in the chat, but also the QR code is on the slide, and it will be on the next few slides as well. And the questions are simply there to help us understand where you're starting from and what you're hoping to get from today. Well. So just a few housekeeping points. The session will be recorded and shared with attendees, as well as uploaded to our YouTube sites. If you can keep your camera off and ensure that your microphone is muted during the main presentations. And again, don't forget to complete the survey. But also, if you have any questions, please use the chat function to post your questions there as we go along, because we will answer and pick them up after the presentations towards the end of the session. So for the agenda today, I will be starting with a short introduction to why genomics matters in cardiology. And a few key terms I hope that will make or will help everything that you hear make sense. And then we're going to hear from our fantastic specialist speakers. We've got Georgiana Nicolau, who will talk on the sudden unexpected death pathway. We've got Stephanie Scott, who will focus on inherited cardiac conditions across families. And finally, we have Angela Cazzo, who will cover familial hypercholesteremia and finding why finding it early is so important. We are then going to move on to quick Q&As, and then I will finish by highlighting some education resources and some next steps. So if my slides move, that would be good. Right. So I'm going to start by kind of taking a step back. So before we get into genetics or genomics, I think it's worth reminding ourselves of the scale of cardiovascular disease in the UK. More than 8 million people are living with cardiovascular disease. Every 3 minutes, someone in the UK loses their life to it. That's just over a quarter of all deaths, around 170,000 people every year. We also know that approximately 340,000 people are living with a genetic heart condition. And while these numbers are kind of striking on their own, I think it's also important to recognize that the burden isn't experienced equally. Outcomes can vary significantly between different communities, which also highlights why accurate data, including ethnicity recording, really matters. But when you put all of that together, it also reminds us that heart disease isn't just something that affects older people or people that look unwell. It can affect people who are young, active, and seemingly healthy, and often with no warning. So until something serious happens. So I'm going to give you a few seconds. And just out of interest, in the chat, which of these do you think genomics helps with most in cardiology? So just pop in the letter that you think helps the most. So I can see a few B's that come in there, which really fits in with the family focus that we're going to talk about next. So identifying who else may be at risk. However, I think we can say that genomics actually helps with all three. So how many of you have cared for a young person with a cardiac arrest, or someone with unexplained fainting, or a family where heart disease seems to run through generations? Often, those situations aren't just bad luck. Sometimes the reason is written in someone's DNA. And that's why genomics matters in cardiology. So in practical terms, it helps us do a few really important things. First, it helps us predict risk before disease develops by identifying people who may need closer follow-up. Second, it helps us diagnose inherited cardiac conditions and guide treatment and long-term management. And that might mean being a bit more cautious with certain medications or monitoring someone more closely. And thirdly, it helps us think beyond the individual patient. It helps us think about families, because if one person has a genetic heart condition, relatives may also be affected. This isn't rare, and it isn't limited to a small number of families. It's sitting quietly in the background of everyday practice. And ultimately, the aim is to prevent future cardiac events, not just react when something has already gone wrong. So genomics gives us another tool. It's another way of spotting risk earlier, sometimes before the person themselves feels unwell. So my aim today isn't to go into specific conditions, because our expert nurses are going to cover that. I just want to give you some building blocks, so the rest of the talks, I hope, click into place. So people often use genetics and genomics as if they mean the same thing, but there is a small difference. And I think one way to think about it is to imagine your body as a huge library, and the entire library is your genome. It's all of your genetic information. The library is organized into bookshelves, and those bookshelves are like chromosomes. So those are long strands of DNA that organize and package our genes. Inside those shelves, there are thousands of books, and each book is like a gene. And a gene is a small section of DNA that contains instructions, for example, how to build a protein. And proteins are the molecule, the molecule, oh, goodness, I can't talk, sorry. Proteins are the molecules that give our body, or that do most of the work in our cells. So like helping the heart muscle contract properly. So genetics is when we focus on one book at a time. We might look closely at a single gene that's linked to a specific heart condition. Genomics, meanwhile, zooms out. It's like stepping back and looking at the whole library, how all the books work together, and how variations across many genes can influence someone's health. So let's talk about alleles, because you may hear that word too. An allele is simply a different version of the same gene. So it's like a different edition of the same book in our library. And the book has the same title and purpose, but there may be small spelling differences in the text. So those differences reflect changes in the DNA sequence. And many of these changes don't cause any problems at all. But sometimes a change can affect how well a gene works, and that can influence how the body develops or functions. Most of our genes come in pairs. We inherit one copy from our mother and one from our father. So we usually have two alleles of each gene. And those two versions may be identical, or they may be slightly different. But understanding those differences across genes, chromosomes, and the whole genome is really a key part of genomics. So just to briefly look at how genetic conditions can be passed down. So as I've said earlier, for most genes, we have two alleles, one from our mum and one from our dad. And as I mentioned before, many DNA changes are completely harmless and simply make us unique. But occasionally, a change significantly disrupts how a gene works, and that's when it can contribute to disease. When that kind of disease-causing gene occurs, the way it's inherited can follow different patterns. In a dominant inheritance pattern, just one altered copy of the gene is enough to cause a condition. So if a parent carries that particular gene change, there is a 50% chance or 1 in 2 chance that it will be passed on to each child. Each pregnancy is an independent 50% chance. And that's why we often see dominant conditions affecting multiple generations within a family. In a recessive pattern, a person needs 2 altered copies, one from each parent to be affected. Parents can be completely well, but carry 1 altered copy. If both parents are carriers, there's a 25% chance their child will be affected, a 50% chance the child will be a carrier, or a 25% chance the child will inherit 2 working copies and be unaffected. So in cardiology, you'll see both of those patterns, but inheritance can sometimes be more complex than these models. However, I think understanding these basics kind of helps explain why we ask about family history and why one diagnosis can have implications for siblings, children, and sometimes wider family members. So again, our specialist speakers are going to talk about specific conditions and services. My aim today has simply been to give you some language and concepts so that when you hear the terms genes, alleles, dominant or recessive, they feel familiar rather than intimidating. And genomics in cardiology isn't just theoretical. It has really very real implications for how we assess families, organize testing, and support patients after significant cardiac events. So I hope that's been a bit helpful. To bring it into the NHS context, I'm now going to hand over to our first speaker, who is lead nurse Georgiana Nicolau, who will talk through the NHS and the coronal and sudden unexpected death pathway and how these processes support families at what is often an incredibly difficult time. So Georgiana, are you sharing your slides?
I'm happy to, yes. It may be easier to move through the slides if I share my own.
Okay. I'll stop sharing.
Okay.
Do you want to put it in full?
Yeah.
That's it. Yep.
All right, fantastic. So thank you for having me. Good afternoon, everyone. My name is Georgiana. I am a lead specialist nurse in inherited cardiac conditions at University of Hospitals Birmingham, and I'm also acting as pathway coordinator within the Central and South Genomic Medicine Service Alliance, but I focus mainly on the West Midlands side. So I will provide a brief overview of the NHS and coronal sudden unexpected death pathway, discuss a little bit about how this pathway started, why we needed it, and where we are at the moment. So very sadly, in the UK, we do have a very big problem in that a lot of young people are dying from preventable deaths. So an estimated 750 people die suddenly and prematurely every year from an inherited heart condition. And these are conditions that, had they been identified and treated early, the risk of premature death could have been significantly reduced. And you may look at this pie chart and realize that these sudden deaths only account for 4% of the overall cardiac deaths which occur in a year. But this is what those 4% actually look like in real life. So every week in the UK, 12 very young people under the age of 25 die. And this is why this pathway really was initiated, because we know inherited heart conditions are often silent. So in the majority of cases, the first symptom of the condition can actually be the sudden death itself. And prior to this pathway, we really had no nationally agreed system to retain tissue. We know that genetic testing can provide an answer to these deaths, but without tissue, we cannot do genetic testing. And we also had no system in place to ensure post-mortem genetic testing was being done regularly for these family members. And the person has passed away. And this was leaving a lot of families at risk. And without tissue retention, we were missing the only opportunity to confirm a genetic diagnosis on the person that had died, but also we could not protect those that we were not aware they existed because we were not identifying who else in the family was being at risk. And this was leaving family members, without answers, without support, and potentially at risk from dying suddenly themselves. And this is why this pathway was created, to change that. So the pathway has three main aims, the main one being to increase the number of family members that are being assessed into the NHS via ICC services. And we do this by improving the links between the coroners, who are the entity that's first made aware of someone dying suddenly, and then the NHS through the ICC service, which is the service where the family will end up being assessed for this condition. Then another aim was to increase the rate at which we retained tissue from the people who die suddenly, and the rate of testing of that tissue. And we do this, first of all, by explaining to the family members why we need to retain and test that tissue, and also by training coroners and pathologists on the importance of retaining that tissue, because ultimately they are the decision makers when it comes to tissue retention. And then last but not least, we wanted to improve the experience of these family members. And this was achieved by ensuring they were promptly referred into the NHS, into these services. And again, we achieved that by having a close collaboration between the coroners, the pathway coordinators, and the NHS. This is just a very brief timeline of how this started. Essentially, just when COVID began in 2020 is when we began the work, but then we were a little bit delayed because of COVID. So the planning stage took place between 2021, 2022, when a number of very important stakeholders got together and designed this pathway. And then it was piloted in all 7 GMSAs in England. It was very much a multi-agency model whereby we collaborated with coroners, with pathologists, with ICC clinics, genomics labs, and charities to deliver this. We provided training for coroners and pathologists to ensure, we had this standardized model when it came to gathering consent and to referring family members. And another thing that this pathway brought into fruition was the creation of this role, which we call it an ICC coordinator. It is essentially a role occupied either by a nurse or by a genetic counselor, and I will talk a little bit about the role a little bit later on in my presentation. But essentially, it is a linchpin role in that it connects all the stakeholders together, keeping the family in the loop and making sure, the whole process is delivered smoothly. After the pilot phase ended, after the 2 years, it was evaluated. It was deemed to be successful. So we received further funding to begin a national expansion of this work. So from 2024 onwards, we've undertaken this controlled rollout whereby we started with 7 coroners, and we are now at about 50 or so coroners that have been enrolled into this pathway in England. So I'll just show you how the pathway of a family who has lost someone suddenly looked like before we started this work. So this is before 2022, essentially. Someone would have died suddenly, and unfortunately, the tissue that could have been retained at post-mortem was either never retained, or it was retained, stored, and often destroyed because nothing was done with it. And we know that without tissue, the genomic lab really can't do anything, and it was really a missed opportunity because they're there to deliver, a lot of value when it comes to genetic testing. But without retained tissue, they were not able to do any analysis. And then another major missed opportunity was that the onus to seek a referral into the NHS was left to the bereaved family members, and oftentimes they were never coming forward for screening until it was very late, and another family members would pass away in the same family unit. So the whole pathway really could take years from the time someone died to the time some of the relatives were actually being assessed into the NHS. And the way we try to change this is by bringing some of the elements much sooner to the time where the person died. So we would try and retain tissue straight away, and we will activate genetic testing very, very close to the time of death. We also try to deliver this routine retention of spleen tissue, making sure that this happens in all the regions, not just in some of the regions. We try to ensure there is a faster and more joined up care by linking cardiac pathology, so that's the post-mortem of the heart, genetic testing, and then the family screening of those who may be at risk. We're also aiming to ensure that there is an earlier and a more targeted assessment of relatives, because we know this has potential to prevent further deaths. And overall, this pathway improved access to RCC services for family members. So this is talking about how setting up this pathway looks like in real life. So essentially, it all starts with funding. So far, funding has been received from the NHS England and the BHF. Once funding is accepted by the trust, they will recruit the role of the ICC coordinator. Once the ICC coordinator is in post, there are 3 steps that need to happen before the site is considered live. So we meet with a senior coroner for that region to make sure they are on board and they're happy to be enrolled in this pathway. Then we also meet with their team, and their team are comprised of coroner officers and pathologists, and we want to make sure they are aware of their roles and responsibilities. Once these elements have been completed, then the site is classed as live. Essentially, the pathway is live for that particular coroner, and they will begin to refer cases. This whole process can last months, and in some regions have even lasted up to 12 months. There is a lot of local variation, unfortunately. The pilot phase has been evaluated, and some of the key findings were that the pathway itself is very effective. So during those 2 years, when we were piloting this work, we've identified 136 cases, out of which nearly 600 family members were deemed to be at risk, and they were invited for screening. The evaluation, which was carried out by this external company called Bright Purpose, also noted that the role of the ICC coordinator was essential, because in those places where there was no coordinator, they noticed a breakdown in service. Overall, there is a very minimal burden on the coronial service itself, so we're not really asking them to do anything differently. The main burden comes to costing, staffing. So that's the IC coordinator salary, represents a huge burden for the project. And the fact that we need more sustainable funding. So we have received short-term funding from the BHF, like I mentioned, and NHS England, but we don't have a solution for more stable funding stream at the moment. Perhaps one of the biggest takeaway points when it comes to that evaluation was the family experience. So the evaluator sat down with these families and they've interviewed them to assess their experience. And overall, the families felt very supported by this pathway, and they felt that the care they received was very much personalized to their needs. They felt they were able to build a rapport with the IC coordinator, and they had the confidence that someone was holding all the threads together. They felt very well informed. The only criticism we've received was when it came to some of the timings. They felt that the genetic test results were taking a little bit longer than they would have liked. So that's something we continue to work on. Now, there were many challenges, and I'm sure that we will continue to have even more, but some of the main challenges that we've noticed, I won't cover all of them, but some of them were linked to engagement delays and resistance from some coroners. So initially, some of the coroners were against the pathway, thinking that we were going to ask them to change their practices or do extra work. And as you know, they're already very overworked. But we were able to overcome that by building that early relationship and meeting with them and explaining that actually we're not asking them to do anything extra or differently. It was more about having a more structured approach than doing anything differently. Another pressure came from the workload itself. So by identifying these cases, we were creating a little bit of extra pressure for the NHS, for the ICC clinics, because we were asking them to actually review these family members a lot quicker. and that created a little bit of pressure when it came to that. And then perhaps the biggest challenge of them all is when it comes to long-term funding and some of the financial strains, particularly a recent challenge that we were able to address within our GMSA region was linked to the production of RNA later kits. So you may be familiar with RNA later. It is a solution that's used to preserve the DNA. And we need to find a way of transporting the sample that's retained in the mortuary to the lab where it will be analyzed. One way of doing it is on dry ice, but that's very expensive. Another way of doing it is by submerging the spleen into this liquid, the RNA later, and then shipping that at room temperature through a regular carrier, which is much more cost effective. Within the past GMSA, we're actually very fortunate. We're able to produce 150 kits, which will be very soon distributed to all the mortuaries in the region to facilitate the transfer of tissue from the mortuary to the genomic lab for analysis. I also wanted to touch a little bit about the role of the IC coordinator. So this is very much a nurse-led model or a genomic counselor model. And it's important to talk about this because it's a change from how things used to be before when it was very much consultant-led. So what this model has brought about was that the patient and the family felt very much supported by our approach to their care. So we were able to offer appointments a lot sooner. Most of our appointments are virtual, which reduce the hospital visits. The nurse or the genomic counselor will have this appointment with the family members, will triage their symptoms, and will be able to fast track them into the NHS for assessment. We were also able to ensure a more standardized referral pathway, which meant that we improved the length of time that they were waiting to be seen, had they had to be seen by a consultant in a regular clinic. And we're also able to ensure their family members were also being assessed in a timely fashion, as well as those family members who perhaps were out of area. Whereas before they had to rely on their own GPs to seek a referral, and now we're able to collaborate with other IC coordinators in the region to make sure they were being very swiftly referred to their nearest ICC center. And the BHF has recognized the importance of this role because they have very recently just committed to continuing to fund this. So they have awarded us another £1.4 million to cover us up until October 2027. So far, this money is being used to fund 17 sites. So that's the salary for the IC coordinator, but also to maintain the pathway continuity until a more sustainable funding stream is found, either through NHS England or through the development of the neighbourhood health services. And yes, overall, the pathway has been successful. We're still very much work in progress. We've enrolled about 70% of the coroners in England, and we have another 30% to go. And once that work is embedded, we will move on to the second arm of the pathway, which I haven't touched in my presentation because it hasn't started yet. But the second part focuses on the survived cardiac arrest. So those people who actually survive a cardiac event. So perhaps in the next meeting, I'll be able to talk about that. Thank you very much.
Well, Diana, thank you so much for that and outlining the pathway. I think it just really highlights how structured and coordinated response needs to be at really a challenging point for families. So thank you so much. Just a reminder for everyone, if you can pop your questions in the chat. And Georgiana, are you? We'll have questions when we've finished all the presentations. So I've just had a message. I think there's a fire alarm going off where Stephanie is. And I wanted to check. Steph, are you available? Or Angela, are you ready to go?
Hi, Phil.
I can go now if need be. Where are you at, Steph?
Yes, please, Angela.
Okay, perfect timing. Right. I'll try and share my screen. Steph, are you on sharing your screen at the moment?
No, you can go ahead, Angela.
Okay.
So just to give you a quick introduction, Angela. Angela is Kazo is our clinical nurse specialist at Wessex Clinical Genetics, who is going to do a presentation on familial hypercholesterolemia, which is a common inherited conditions. I think, let me know if you want me to share, or otherwise you're ready to go. There you go.
It says I'm sharing, Phil. Can you see it?
I can, but can you put it on slideshow mode?
Right. Let me share. I've got content only, stand out, side by side, reporter. Is that okay?
Yeah, so if you look at the top there, it says slideshow at the top by the tabs.
Oh, yeah.
You just go to slideshow there on the other side. Yeah.
Yeah.
Go across to slideshow after animations, just above the tabs there.
Oh, yeah.
Yeah. And then you can put it, I think you can put it from the beginning.
Is that it?
Not yet. So have you clicked from the beginning there?
Yep. Mm-hmm.
Yeah.
I've clicked from beginning.
Are you sharing two screens?
Well, I'm trying not to, but when I press
Unless you
to
want
put
me
it
to
for
share.
screen show, there's two.
Shall I share the slides here, Angela?
Yeah, I think I'll come out. You share them, and I'll tell you when to change.
Okay.
Sorry, everybody. As normal.
Have you got it?
Technically, yeah. Is that okay? Can you see me? Sorry, the sun is a little bit bright today as well. Just change my blinds a little bit. Sorry about that, everybody. Thanks, Phil, for inviting us to speak today. My name is Angela Cazzo. I work as a clinical nurse specialist for Wessex Clinical Genetics within the familial hypercholesterolemia team. I've done this job for about 11.5 years now. Like a lot of nurses who come into this post, I'm a cardiac nurse by background. So my last job was ward manager on coronary care, and I've also worked in cardiovascular medicine and surgery as well. So we're going to talk a little about FH, which we will call it, because obviously familial hypercholesterolemia is a giant mouthful, and some of what we do in the service and how we've worked towards increasing diagnosis of individuals and families. Next slide, please, Phil. So FH, what is it? Well, it's probably one of the commonest genetic conditions that you'll come across it within the cardiovascular world. We think that probably the incidence of FH is probably at least 1 in 250 people. When we first started testing, we quoted the incidence as sort of 1 in 500, but the more that we've tested, the more we've found that it's commoner than we thought, essentially. So like most cardiovascular signs, high cholesterol isn't something you can tell by looking at somebody necessarily. There are some subtle signs that I'll talk about a bit later, but generally, like blood pressure, etc., cholesterol is something you need to have checked to know about it. And things like the standard NHS health checks and things that are diagnosing more people, but 40 is quite late to be diagnosed with FH, as I'll explain. So part of the work we've been doing is to try and make sure people are diagnosed as early as possible. So FH is an inherited disorder of lipid metabolism. So it's autosomally dominantly inherited. So if you have it, there's a 1 in 2 chance of your children having it, and that's how it gets passed on in families. And it affects the way the body gets rid of its LDL, or bad cholesterol, essentially. And if you have FH, you have too much LDL or bad cholesterol from birth, essentially. And it's this increase in cholesterol metabolism and lack of LDL removal that result in this accelerated atherosclerosis. And some early studies, and one of the some Dutch colleagues at a recent conference we went to, apparently there is a study they've done has shown that atherosclerosis children can show signs of that who have FH. So initially we do test children for this, which I'll talk about, but it was thought that, this was just in case, but actually now we've got sort of firm evidence that atherosclerosis can happen in childhood in patients with FH. So this is why early treatment is essential to reduce the risk of premature cardiovascular disease. And obviously, therefore, early diagnosis is absolutely vital. Next slide, please, Phil. So why is it important to diagnose people with cardiovascular disease? Well, I'm sure you're obviously all aware of some of the risks of hypercholesterolemia. Obviously, ischemic heart disease, cardiovascular disease is the main reason why people die in the Western world and has been for a long time. Also, it can increase your risk of peripheral vascular disease, acute coronary syndrome, obviously stroke, erectile dysfunction. And we did have a chat about whether we're going to put this on the slide, but I think sometimes it's something that patients can present with, erectile dysfunction. Obviously, it can be embarrassing, but it can often be a sign that there can be cardiovascular things going on. So it's always just a thought that if someone does present with ED, that a cholesterol check, blood pressure check, etc., should be part of the workup, really. So people who have FH, if it's untreated, particularly in the younger age group, have a 100-fold increased risk of death from heart disease when compared to those of their peers who don't have FH. So that's pretty grim, to be honest. And what we quote when we see people is we know that patients with heterozygous familial hypercholesterolemia, so they've inherited one gene from a parent rather. So 50% of men who have FH, if it's not treated, will have some sort of cardiac event by the time they're in their 50s. Now, who that is can depend greatly on lifestyle and diet, which can obviously worsen things, but we do see a lot of healthy patients in clinic who otherwise do not have a lot in the way of risk factors and comorbidities who have had cardiac events young. In women, the incidence is slightly less, so we quote 30% of women by the age of 60, and that's really because of our female hormones that protect us, our estrogen and our progesterone, that protect us a little bit from heart disease. So with women, we see the risk going up often post-menopause, when estrogen is quite good at lowering cholesterol, so we often see in the perimenopause, menopausal stages that women's cholesterol can go up. There is a rare sort of FH called homozygous FH, where you can inherit two genes, one from each parent, and it gives a very severe phenotype. Not very common, probably 1 in 600,000, we think probably potentially could have that. It happens more in families where there's consanguinity or marriage within families. But these are people who we need to diagnose very early because their life expectancy is very low and young if we don't treat them. Next slide, please, Phil. So how do we know if someone's got FH? Well, obviously we need to know their cholesterol levels. That's pretty important. Obviously, in the Western world, cholesterol levels generally are increasing due to lifestyle and diet. But when we look at people who could potentially have FH by looking at their total cholesterol and their LDL cholesterol. So if someone has a total cholesterol of greater than 7.5 millimoles, and that combined with a history in the family of premature coronary heart disease or known very high cholesterol in a first degree relative, that's people we should be looking at. In primary care, they're particularly looking at people younger than 30 with a total cholesterol of greater than 7.5 and people over 30 with a total cholesterol concentration greater than 9. Next slide, please, Phil. So we use something called the Simon-Broom criteria when we're assessing suitability for genetic testing. Simon-Broom was somebody who had FH, I believe, and his wife was one of the instigators of trying to get some sort of diagnostic criteria for FH. So we look at adult and children, and we look at the cholesterol levels that you can see on the screen. We do know that this is a guide only, and we do see people with FH with cholesterol levels much lower than this. Children, it can be lower. when they're young. It's normally elevated, but it can be lower than this. So this is why the genetic testing is so important, because if we went on lipid levels, we would probably miss people who have the condition. So the family history, we look for a family history of cardiovascular disease or MI in a first or second degree relative, 50 or less in a second degree, and 60 or less in a first degree relative. Again, this is all guidance. We look at each case individually. We also look at some families don't have cardiovascular disease because we are getting better at diagnosing people with FH and knowing more about cholesterol. We can see whole families where nobody's had cardiovascular disease because everybody's had their cholesterol checked and been treated from a young age, and that's what we're starting to see now. Next slide, please, Phil. So what do we do in primary care, or what is done in primary care? So recently, in the last, I think it was about 3 years ago, there was what we call a DES indicator came out, which was driven by NICE guidance, which encouraged primary care GP surgeries to systematically try and identify people who had FH. Again, looking at the lipid thresholds we talked about before and against the Simon-Brew criteria. And this is obviously related to the DES and the QOF indicators, sort of focusing on the percentage of patients with high total cholesterol who've been assessed or diagnosed with FH. And they did this by using a common tool that they used to use, this was something called FAMCAT, which is a clinical case finding tool designed to find people with FH. So obviously this tool scans the information from the GP practice and comes with a list of likely people who may have FH. Obviously, like all databases and system, it's relying on the information that it's assessing being appropriate and well filled in. But on the back of this, we had a vast increase in referrals, which has sort of dipped a little bit, but is still much higher than it was when we first started the service, which is great. So people, I think, in primary care are thinking a lot more about FH and who to refer. Next slide, please, Phil. So when we talk about, I've talked about cholesterol not having really signs and symptoms. There can be subtle signs and symptoms of high cholesterol, and I'm sure some of you will have seen these in your practice. Probably the commonest is the bottom right, something called a corneal arcus, which isn't indicative that you have got FH, but is a sign that you've normally had high cholesterol for quite a long time. It's seen very commonly in the elderly and isn't particularly significant in particularly patients over 70, 75, because it can happen with age. But a young person with a corneal arcus is significant, and it is something that if you see that, you should make sure the cholesterol levels are checked. Above the corneal arcus, you can see something called xanthelasma around somebody's eyes, which is something you may have seen again. And this again can be a sign that somebody's had high cholesterol for quite a long time. It's not normally, they've just had high cholesterol for a little while. When you have high cholesterol, it likes to build itself up in peripheral areas, which is why it goes to the cornea and the eyelids and just sort of settles there. So again, a sign of xanthelasma, if someone hasn't had their cholesterol checked, should be a real sign to have that done. The two pictures on the left refer to something called xanthoma, which are normally very indicative that somebody does have FH. So it's a sign of fat buildup along the tendons, and it can be any tendons. We traditionally see it, as you can see, on the Achilles, in the heels, and also on the knuckles. And it's sort of fatty lumps that move up and down the tendons. And normally when someone has that, it can be a definitive sign that they do have FH. Next slide, please, Phil. So when somebody's referred to us and we've done the initial triage, we've thought they're acceptable to be seen in clinic, we will make an appointment for them to be seen, normally face-to-face if we can, but we do video and telephone consultations as well. And we have an hour with people, which is quite unique, really. Very few health professionals have that long with somebody, but it does give us time to do everything we need to do. We see the patient, we discuss obviously the condition, we talk about risk factors and cardiovascular disease often, and we draw their pedigree or family tree. And we're particularly looking at who in their family may have high cholesterol or have had an early cardiovascular disease or any cardiac cardiovascular disease. And we make sure they fulfill our criteria for testing. And if they do, and that the patient is then happy to proceed for genetic testing, we will take their blood in the appointment if we're seeing them face to face. The majority of people who come to see us have had a reasonably up-to-date lipid check, but if they haven't, we will recheck their lipids in clinic. Or if it's a relative coming to see us for cascade or family testing and haven't had a cholesterol check, we will normally check their lipids in clinic also. We send the sample for genetic testing, and in FH we use something called next generation sequencing, which is high throughput sequencing, so multiple samples, and the turnaround time is, we say, between 2 to 3 months. Most of our results are coming back within a couple of months at the moment because we're getting quicker and better. We have 5 genes on our panel, 4 dominant and 1 recessive. The recessive one is a very rare gene that we don't often find, but it is added to the panel. If we find our patient to have FH, that's when cascade or family testing of adults and children begins. Next slide, please, Phil. This is an example of a pedigree or family tree of a family that we have seen in clinic. I apologise, it's not that big, but I just wanted to sort of talk through, and it demonstrates quite nicely what we have done in clinic and how we've diagnosed family members. So you can see on the left of the screen there's an arrow pointing to a circle and says 35 next to it. So this was a woman we initially saw in clinic, a 35-year-old female. Circle means female, square means man. And that woman was referred to us with high cholesterol. So the red in the circle means she had high cholesterol. The blue means she was on a statin. So she was referred to us. Normally, if you eat reasonably well and you have a good diet, at 35, your cholesterol isn't normally high. Hers was particularly high, so she was referred to us for consideration of testing. She was found to have FH, and then testing, we looked at, in the first instance, her first degree relatives, so parents, siblings and children. And you can see in this pedigree, she had a brother who lived in the USA who also had high cholesterol and had previously had an MI at the age of 37 and 4 stents. And unsurprisingly, he was found to have FH also. She also had a sister who had normal cholesterol and was found not to have the condition. This is a condition that we test children for, which I'll talk through in a bit more detail later on. But you can see both this woman's children were tested for FH and both were found to have it, unfortunately. They were aged 6 and 4 when we tested them, and they both had cholesterol over 8 when we saw them in clinic. So children's cholesterol levels can vary enormously, but it can be very high from very young. And this is why we want to know from as young as possible if children have FH, because a lifetime of having a cholesterol of 8.5 greatly predisposes you to early cardiovascular disease. So when we tested the first degree relatives, we also found that her mother had high cholesterol. You can see above 59-year-old woman. She had high cholesterol for a long time, was known to be on a statin. And as you can see from the family tree, if you look at the generation above, her father had high cholesterol and he died from a MI at the age of 35, which is very indicative of FH. And that was why she had had her cholesterol checked, because there'd been a young death in the family. From her being tested, we then tested her siblings. So one of her sisters was found to have FH. Luckily, both of her children were unaffected, so that no further testing needed to happen in that family. And her other sister had a more normal cholesterol, so again, her children will not need to be tested. So that family tree gives a really good sign, I think, of the work and what can happen from diagnosing with just one person in clinic, the network that develops in the cascading that we do. Next slide, please, Phil. So pediatric testing. So FH is quite unique in that it is one of the conditions that we do test children for. And the reason being is because it's something we can treat and manage from a young age, and because the evidence is starting to come through that atherosclerosis can happen from a young age. There's guidance from NICE on paediatric FH testing, and the guidance is that children should be tested as soon as possible if a parent has a confirmed FH genetic variant, ideally by the age of 10. We tend to offer testing from the age of 2. And any age from there, as I say, ideally by the age of 10, but obviously some children come to us later, and we will diagnose them. We currently have 2 paediatric FH services in our region run by paediatricians, and myself and my colleague Catherine attend those. The first one is at Southampton General by Dr. James Nurse, and there's one at the Royal Berkshire Hospital, Dr. Nicola Pritchard. And we've diagnosed probably, I would think, getting on for about 200 children with FH. I haven't got the exact figures, and quite a lot of those children are on statins. Statins are licensed from the age of 10. The younger you go on them, the lower dose you tend to need long term, and children respond very well to a very small dose of atorvastatin, generally 10 milligrams. So when we see them in clinic, ideally we would do a lipid profile and a genetic test at the same time. As I say, we do that from 2 years old. If for any reason we couldn't do a genetic test, we sometimes have children referred to us where a parent has died suddenly of cardiovascular disease, but we haven't had a chance to test the parent. In that case, we would often check the child's lipid levels, and if they're raised, go on to test that child for FH. Next screen, please, Phil. So as I say, just to touch on what we do with children, mainly with heterozygous, but some children obviously do have homozygous FH. This really is something that should be managed in secondary care, other guidance. So GPs are generally reluctant to test and manage children for FH because it's sort of unknown territory for them. So if there isn't a paediatric FH service, and there's not actually a huge number of those at the moment in the UK, they can be referred, and some adult specialists will see children in lipid clinics or metabolic clinics. And what we do with children is we also monitor their growth and pubertal development alongside. And most of the research that we've done has shown that early diagnosis and treatment with statins doesn't have any effect on children's growth or puberty, that they're safe and well tolerated by children. There's been recently that a new paediatric register has been developed by the University of Nottingham. It's kind of in the pilot stage at the moment, but us in Southampton and several other paediatric services are currently entering data onto that. Basically, we're looking at age of diagnosis, cholesterol levels, treatment, etc. And we hope to have then a nice defined database of information that we can use going forward. Next slide, please, Phil. So when we talk about FH testing, it has been tested for quite a long time, but not sort of in a formal way. We've probably been doing it for about 10 years now. So I came into post in 2014. Initially, a lot of posts were funded by the British Heart Foundation initially, because we knew it was a common condition. We know we just weren't diagnosing enough people with it. There was some testing done about 15 years ago, something called FH20 test, which was when they first started to identify the genes on the panel for FH testing, and they looked at the 20 commonest genes and tested some people for that. We now have hundreds of gene variants that we know about, so our panel is much bigger than that now. So the NGS we then had a 4-gene panel. We then did something called the 100,000 Genome Project, which some of you may have heard of. And out of that project, we found another gene that we knew was responsible for giving the phenotype of FH, a certain mutation on the ApoE gene. So that has now been added to our panel. So we now have a 5-gene panel for FH. And come after 100,000 genome is whole genome sequencing, which we're doing quite a lot of now. And as part of the whole genome sequencing, we are looking for additional findings, which are things that aren't related to the initial diagnosis of why the person was referred, but are things that can be found and managed, treated. And FH is one of the things they look for. So if somebody is referred for whole genome sequencing for something else, they may be found to have FH. And we've had several families where we've diagnosed parents and children with FH and been able to do more extensive through the family. Gene therapy is something that I'm sure we'll be talking more about in the future. It's not something we routinely do for FH or for a lot of conditions at the moment, but there is a study, the VERVE study, which is starting, which is looking at gene therapy in FH patients. And there are early talks about us being an area that could pilot some of that work. So that's quite exciting work in the future. Next slide, please, Phil. So if you're a clinician and you're thinking about wanting to refer to us, then we take referrals from both primary and secondary care. Primary care, I've put the links on there, and I know Phil is going to distribute the slides at the end. Basically, we use an e-referral system, which is a link to our referral form, and they can be referred into us at Wessex Clinical Genetics. Secondary care can refer to us. Normally, things are sent via email with a copy of our report, and they can be sent via that email address there. Next slide, please, Phil. These are just some of the references of what I've talked about today. So most of the information around FH guidance is from NICE. Public Health England put out a paper in 2018. And if you're interested in the cost effectiveness of cascade testing, there's a paper that was done by our boss Melanie Watson and some of her colleagues in 2017 that is worth looking at. Next slide, please, Phil.
I think
Any
you've
questions?
done.
Yeah,
So
I think I am.
thank you so much, Angela.
You're welcome.
That was a really great overview of FH. We are going to have questions. I hope Stephanie is available now or able to talk now. So if you're happy to wait, if you're happy to
Yes, Phil.
to start after that for questions. Hi, Steph.
Hi, Phil.
So I'm sharing your slides, aren't I?
Yes, please.
Okay, I need to find them. 1 second. Where are we? We are, yeah. There we go. Thanks very much. We have got Stephanie Scott, who is the clinical nurse specialist for the inherited cardiac conditions at Wessex Clinical Genetics. So you just let me know when you want me to move on, Steph.
Thanks, Phil. Thank you for inviting me to speak today about protecting ICC families across generations during Heart Month. As you said, I'm Stephanie Scott. I'm the clinical nurse specialist for inherited cardiac conditions at Wessex Clinical Genetics Service, and I'm based at University Hospital Southampton. So we could have the first slide, please. Phil, thank you. So firstly, inherited cardiac conditions are not rare. These patients may be asymptomatic and not presented yet, or they may be present in all of our cardiology clinics, no matter the speciality or the age. And probably 1% of the population has an inherited cardiac condition. So these conditions comprise of cardiomyopathies such as hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic cardiomyopathy, as well as others, and channelopathies, which are heart rhythm disorders such as long QT, Brugada, CPVT, aortopathies, which affect the aorta, such as Marfan syndrome, familial thoracic aortic aneurysm and dissection, Loeys-Dietz and vascular Ehlers-Danlos syndrome, and also SADS, which we've talked about, and FH. Also, other causes of inherited cardiac conditions may be metabolic, mitochondrial, neuromuscular, and there's also phenocopies of hypertrophic cardiomyopathy, the hereditary amyloidosis, and Fabry's disease to consider. So for the purpose of this talk, I'm focusing today on a case study of a 45-year-old gentleman who had an out-of-hospital cardiac arrest, VT-VF arrest, whilst playing for a charity rugby match. And fortunately, he was successfully resuscitated on the pitch by a bystander with an AED. On admission, his ECG showed sinus rhythm with anterior lateral T-wave inversions, and he had an echo which showed mildly dilated left ventricle with an ejection fraction of 45 to 50%. He went on to have coronary angiogram, which showed normal coronary arteries, and he had a cardiac MRI, which showed a mildly dilated LV with an ejection fraction of 45%, with late gadolinium enhancement, which was ring-like in appearance, and therefore he had a secondary prevention ICD. This gentleman was previously well, he attended the gym 3 times a week, and he hadn't noticed any previous cardiac symptoms in the past. So this came out of the blue for him and his family. So next slide, please. So this gentleman, there was a clinical overlap in his phenotype and between dilated cardiomyopathy and arrhythmogenic cardiomyopathy. And with these conditions, there's clinical overlap in phenotype and genotype. So in idiopathic dilated cardiomyopathy, there is a prevalence of 1 in 2,500 people and presents with an enlargement of the left ventricle with a significant associated mortality due to heart failure, arrhythmias and thromboembolic events. It's typically inherited in an autosomal dominant way, and there is around a 20 to 30% yield with genetic testing of finding the underlying genetic cause. First degree relative screening composes of ECG and echo. With arrhythmogenic cardiomyopathy, the proteins that hold heart muscle together are not developed properly, and this can cause cells of the heart to become damaged, causing scarring and the build-up of fatty deposits as the body attempts to repair the damage. And in the top right-hand corner, you can see the little white circles are evidence of fatty fibrosis on cardiac on the tissue samples there. So arrhythmogenic cardiomyopathy has a prevalence of 1 in 1,000 people. It can involve the right ventricle, but also the left ventricle, and it can be biventricular. And it has substantial mortality due to associated ventricular arrhythmia and sudden cardiac death. Again, typically inherited in an autosomal dominant way, though there may be other inheritance patterns involved. And there is a 40% yield when we perform genetic testing for finding the causative gene fault. First degree relative screening is recommended, which includes echo, ECG and cardiac MRI for these family members, as the MRI can detect the fibrofatty replacement and scarring, unlike echo screening. Next slide, please, Phil. So this gentleman required genetic testing, was offered genetic testing, and using the National Genomic Test Directory, we can see that we required the R132 dilated and arrhythmogenic cardiomyopathy panel. And I would say that the testing criteria for this gentleman would be number 2. So he had left ventricular cardiomyopathy associated with variable degrees of myocardial dysfunction and myocardial fibrosis, plus the ventricular arrhythmia, which presented as cardiac arrest. And we had been able to exclude other etiologies, including inflammatory disorders for this gentleman. Next slide, please, Phil. So all variants or gene faults are interpreted according to evidence with the ACMG, AMG guidelines, so the American College of Medical Genomics, and they're classified according to their disease-causing nature. Class 5 gene faults are classified as pathogenic, so that is disease-causing. They're diagnostic gene alterations, and we're around 95% certain that they're the cause of the condition. They're clinically actionable, so we do make clinical decisions based on these particular gene faults, and we can offer genetic cascade testing to family members for these gene faults, and also patients with pathogenic gene faults are eligible for reproductive options to prevent passing on these gene faults to the next generation. Class 4 gene faults are the next level of evidence down, and they're likely pathogenic, and that we're around 90% certain that they're cause of the heart condition in the family. So they're likely diagnostic, they're clinically actionable, and we are able to cascade test with appropriate counselling of family members that there may be a 10% chance it's not the cause of the condition in the family. So family members that are found not to have likely pathogenic variants, we will still advise to present if they experience any cardiac symptoms, and we will periodically review the evidence every 5 years surrounding these variants in likely pathogenic to see whether the evidence has increased to pathogenic or been downgraded. Next slide, please, Bill. And then class 3 is where we identify a gene fault, but it's currently classified in the evidence as a variant of uncertain significance. So that's a fault in a gene where we're not certain it's got anything to do with the heart condition or not. So whether it has caused the condition or whether it's just part of normal human variation. So there'll be this uncertainty about whether this causes the heart condition. Therefore, it's not clinically actionable. However, in high risk genes, which we'll talk about in a moment, we may review phenotypes in these in family members or diagnostically or with family members diagnostic testing where we find a variant of uncertain significance. We may review the phenotype to see if it fits with that particular gene that we've identified. With family members that are affected with the heart condition, we are able to offer sort of segregation studies. So if they're found to have the same familial gene fault as the proband, then that will increase the evidence over time that it may be the cause of the heart condition in the family. But we still need to wait for it to reach the class 4, class 5 level of evidence to be able to cascade. So this variant of uncertain significance will be reviewed periodically and may be entered into research to see if we can find proof that it causes the condition in the family. Next slide, please, Phil. And then we move on to the null panel. So that's where we have a look at those genes on the panel, and we don't find any faults in those particular heart genes. So there's no explanation for inherited explanation for why the person's developed the condition. So in dilated cardiomyopathy, arrhythmogenic cardiomyopathy, we find this result in around 60 to 70% of people that we test. So there's still be that uncertainty surrounding the cause or the inheritance of these conditions, though it's felt that they are likely to be inherited, though we haven't found the underlying cause because our genetics knowledge is not complete yet. So we will periodically review, sort of update genetic testing in the future based on our new knowledge. That does mean that the proband is not able to access reproductive options, and we're unable to cascade test to other family members. And it means that other family members will need to remain under the cardiac screening programme. So there's a big burden on the NHS when we have a null panel. Next slide, please, Phil. So this is the case study here. So with the arrow is our proband, so the person that we've done diagnostic genetic testing in, and we know that he's, well, I'm going to talk about in a moment that he's been identified to have a DSP pathogenic variant, so class 5 variant. When he presented, we recommended first degree relative screening for his parents, his brother and his 2 children. So that involved ECG, echo and cardiac MRI. Next slide, please. So the genetic test result for the diagnostic genetic test result for my gentleman showed that he had this DSP gene fault. So essentially desmoplankin is encoded by the DSP gene and is the major component of the desmosomes, which are structures that hold the cells together. So that sort of fits in with the arrhythmogenic cardiomyopathy phenotype. This variant was classified as class 5 pathogenic. So this confirms that he had a clinical diagnosis of arrhythmogenic cardiomyopathy. And that meant that we were able to offer pre-symptomatic cascade genetic testing for at-risk relatives. Next slide, please, Phil. So this table is taken from the 2023 ESC guidelines for the management of cardiomyopathies, and it highlights high-risk genotypes with higher thresholds for higher risk of sudden cardiac death. So there's 6 genes that have been entered into the guidelines, and we can see that the DSP gene fault is identified there with an annual sudden cardiac death risk of 3 to 5%. With the risk factors of late gadolinium enhancement on cardiac MRI and an LV ejection fraction of 45%. Some of these gene faults first presentation can be the arrhythmic event without any LV impairment. Next slide, please. So we went on to cascade test his family members, and when we can cascade test family members, there's 2 results that we could get. They have either inherited the familial gene fault, so they're either positive or they're negative. And with positive results, we need to make sure that they understand the insurance implications. So there's currently a temporary agreement with the Association of British Insurers that they don't need to declare the results of genetic testing, but they do need to declare their own past medical history, clinical screening results, and family history. There may be career, driving, exercise, lifestyle implications, and we will need to make cardiac screening recommendations for their first degree relatives. We will provide onward referral to the cardiologist for cardiac screening and surveillance, and onward referral to genetic counsellors for reproductive counselling. If they're negative and they haven't inherited the gene fault, so they've got 2 normal copies of the DSP gene, we can reassure that they're not at increased risk of developing this heart condition, and that will mean that their children won't be at risk either. And we can discharge them from ongoing cardiology follow-up, reducing the demand on NHS resources. Next slide, please, Phil. So going back to our pedigree, which I gave away earlier, so his brother, who was 43, was cascade tested and was identified to have the familial DSP pathogenic variant, which predisposes him to develop arrhythmogenic cardiomyopathy. His cardiac MRI was very similar in appearance to his brother's, with late gadolinium enhancement, LV impairment, and he went on to have a primary prevention ICD. Interestingly, he did have a past medical history of myocarditis in his 20s, and it has been found that DSP variants are associated with myocarditis as well, as that can lead on to arrhythmogenic cardiomyopathy. We also cascade tested his mother, and she was found to carry the familial gene fault, though she had normal screening, and that demonstrates the incomplete penetrance of gene faults and how some people can have familial gene faults that are pathogenic and never develop the condition, though she will be kept under surveillance for a little while longer. that confirmed that the gene fault was inherited through the maternal line, and meant that we were able to offer further cascade screening to that side of the family, so her sister, her brother, and the children of her siblings who had died. The remaining results in the family, fortunately, so both the proband and the brother's children did not inherit the gene fault, so reassurance could be provided there. Next slide, please. And this is a recent paper authored by Juan Kwaski and others from the European Heart Journal in 2025 regarding follow-up of first-degree relatives based on genotype for dilated cardiomyopathy. And I thought it was quite a good sort of visual cue of what we do with family members, although we always treat a family as individual, and this is just a guideline. So essentially with genotype negative family members, we discharge from screening. Genotype positive family members, we do interval screening, typically up to the age of 60 or longer, depending on the family history. Next slide, please, Phil. So what do we do in mainstream in our mainstream joint ICC clinics? What's discussed? So again, this is personalised and individual with each patient. So we discuss their personal experience of their family history or their ICC condition, the condition itself and the inheritance pattern, the strengths and limitations of genetic testing, risk to relatives, ethical issues such as sharing of information, which we support with To Whom It May Concern letters that our probands can pass to at-risk relatives to enable them to access cardiac screening. Sudden cardiac death risk, medication, devices, treatments, interventions, and lifestyle implications, so insurance, driving, career, exercise implications, reproductive options. And we also signpost to support, so the British Heart Foundation, Cardiomyopathy UK, CRY, SADS, etc. Next slide, please, Phil. And I just wanted to briefly talk about gene therapy, cardiomyopathy research. So this is global research that's been awarded by the British Heart Foundation, funding 30 million for the research called Cure Heart, which is trying to develop genetic therapies that may be able to cure cardiomyopathy in the future. So for the person that is affected, but also to family members that have inherited the gene fault to prevent them from ever developing the condition. Next slide, please, Bill. Thank you. And then our referrals to cardiac genetics are by letter to our Wessex Clinical Genetics Service, and there's my email there. And obviously I'm a very small part of a fabulous multidisciplinary team in Wessex, well supported by our consultant clinical geneticist, cardiac lead, Dr. Catherine Mercer. Thank you very much. Thank you for listening.
Very much, Steph, and thank you very much to Georgiana and to Angela for your presentations as well. I think we're going to go on to questions now, but really to all of you, I thought that your presentations were really clear and quite helpful, and you've all covered some really important ground, and I think you've made what can feel sometimes like a complex topic a bit easier to follow. So I am just going to check on chat with regards to questions and go from there. So sorry, just 1 second while I just double check here. Just a reminder, yes, the session has been recorded and it will be available on YouTube. And I can see there is a question here from Jane. for Georgiana. The question, Georgiana, are you still there? Yeah.
I'm here.
Yeah. Oh, I see you have answered it, but it was the question regarding does the service signpost to or direct patients who are tested positive to psychological support services? Did you want to add anything more on that?
No, so patients do receive genetic counselling. It's not psychological counselling. It is genetic counselling if they test positive. Psychological counselling, they can be referred to, but it's very much region dependent. So we have scope to refer, but the family has to belong to a certain geographical region. If they are outside the region, then we'll ask them to go to their GPs and seek a referral, or we signpost them to various charities that can help with that.
And then there is another question there from Charlotte, who says it was really interesting, Georgiana, and thank you. Are there any specific challenges with different cultures, given this requires post-mortem evidence, because she is aware of a neighbor whose husband died very suddenly with a heart attack, but they refused the post-mortem as they are Muslims, and she felt she couldn't go against this.
Yeah, so unfortunately, the next, so this can happen occasionally. It's very rare. The next of kin has the ultimate say. So if they ultimately decline, there is very little that we can do about that. We can provide education. We will speak to them. We'll try and highlight the benefits of having tissue retained, but it is their decision in the end. If they choose not to go ahead with tissue retention, then they still have the option to have cardiac screening, which is equally as important, if not more in some cases. So it's not like they miss on all opportunities. They will just forfeit the genomic element of it.
My question really, and I know you covered it in your presentation, but I just wanted to find out from you what you felt was the most challenging part of implementing the pathway.
Gosh, there were many different challenging things. So I would say workload demand. So mainly because at the same time that we had to approach coroners and deliver training to their teams and implement the pathway in different regions, we were receiving referrals from the regions that had already been established and part of the pathway. Then the fact that not all of us were on full-time contracts, so some of us worked part-time on this pathway and part-time on a regular job. So there were a lot of competing demands and the lack of cover. So when we go on annual leave or if there's any sort of leave of absence, there's no one else to pick up the work for us. So we just come back to more work when we come back to it. And then another challenge in certain region and with certain coroners has been their refusal to engage with us. This is a major national problem. It's not that they don't want to participate, but they simply just don't answer at all our requests. So yeah, that is a challenge.
And so is there a plan for that to be addressed?
So other than us constantly chasing them, there is very little that we can do because they do have autonomy. So although the project is supported by the Chief Coroner for England, and they do encourage all the senior coroners in England to participate, they do have jurisdiction of their own region. So they have the ultimate say in whether or not they will be part of this. And we can't force their hand. So it's just about proactively chasing, being very tactful about it, and careful not to upset them.
Yeah, I suppose that kind of then raises another question about equity across
it does.
Yeah.
And it's a major problem. Yeah, we have, unfortunately, within the West Midlands, there is just one coroner that we've not been able to engage with. All the others have been very, very open and keen to participate. But yeah, it does leave an equity problem.
Thank you. Thank you. I think the next question I think is for Angela, and this is from Emma O'Malley, who says she's a genetic counselor, but she doesn't have tons of experience with FH. And is the penetrance quite variable, or will pretty much everyone with a pathogenic variant develop the condition?
That's a good question, and the longer I've been doing this, the more we're realising there is some varied penetrance in the condition. When we first started testing for FH, we did say very much that if you have the gene, you have high cholesterol, that's it. So it's not like the other inherited cardiac conditions, such as you can carry the gene for HOCM and not have any signs or symptoms. It's rarely like that, but we have found, it's unusual and unlikely, but we have found some people who carry the FH gene who appear not to have such high cholesterol. Sometimes it's marginally raised. Sometimes we have had people with completely normal. But it's very unusual. The rule of thumb is generally, if you inherit it, you have high cholesterol and you have the condition, but there are exceptions, as there are in all cases, really. But yeah, it can vary, even in families, actually. The case study I used showed a family where the phenotype was quite severe, and certain sort of gene changes lend themselves to severer phenotypes. So we have a range of different phenotypes across FH. There's some genes that can give quite a mild phenotype, and other gene changes that can give a more severe phenotype. So things such as deletions and duplications. But it's not impossible for someone to have high cholesterol. This is why we will cascade test anybody who has a relative with a 50 or have a 50% risk of having FH, just because we know there can be a great varied levels within the population.
The next question I think is for you as well, Angela. Okay. It's from Jacob, and it says, is post-mortem cholesterol levels reliable, or are they reliable?
I don't know. Georgiana might be more able to help us with this as well. I don't know. I don't know if it's something they do when there's a sudden death. Do they, Georgiana? Do they do cholesterol levels?
No, I've never heard of post-mortem cholesterol levels. So at post-mortem, They look at the heart. If they notice plaque, then they will recommend lipid profile in first-degree relatives, but not in the person that's died.
Certainly we've never had somebody referred. I mean, we had a case a little while ago where a 35-year-old man who was actually a relative of one of our positive patients who unfortunately hadn't come forward for testing died very suddenly of an MI. And he had a little girl who was 3. So we referred her to our paediatric service, and she's been tested and found to have FH. But we didn't need to test the dad to be able to do that. We had a diagnosis in the uncle. We would also test any children probably who had a parent who died young of a cardiovascular incident, really. So we don't always need to rely on the cholesterol levels. And I don't think certainly it's something that's routinely done at a post-mortem, unfortunately.
I think my question for you, Angela, is, and I actually have a few. Let me see. I think my first question is, what do patients usually find hardest to accept when they first told that they might have FH?
I think there can be a varied response. Generally, some people come to us and they've known they had high cholesterol for a long time. For some people, it's a relief to know the cause, because if you've had high cholesterol for a long time and you've been told to go away and improve your diet and lifestyle, and you've done that and it's made no difference to your cholesterol levels, that can be very frustrating. So for some people, it's quite validating to find they have FH. It depends very much on the family history, I think. If there is a family history of early cardiovascular disease, people generally tend to be very worried about that in themselves, but also for their children. So generally, people who come to see us are generally worried about their children or their first-degree relatives the most. And some can be upset because if the diagnosis is unexpected, it wasn't so with our cascade patients, our family members, it can be harder because they didn't necessarily know they even had high cholesterol sometimes. But most people, I think, are generally pleased to have the diagnosis because FH is very treatable. And the thing to realise, when we treat people with FH and we bring their cholesterol levels down, their risk of cardiovascular disease is then no higher than anybody else's. So treatment is really key for FH.
And I think my other question was going on the physical signs is, do you see those physical signs in children?
Not standardly. You can in homozygous children. So a lot of homozygous children will present with xanthomas in the places that I showed you, but also sometimes on the elbows, on the knees, because their cholesterol can be so high. So a child with homozygous FH can have cholesterol as high as 20 sometimes. So you can sometimes see those xanthomas in those children, and often you do. We had a little girl from Afghanistan recently who did have quite extensive xanthomas, and she had homozygous FH.
Thank you. Going on the questions then, this is for Stephanie. Is genetic testing undertaken in any other type of cardiomyopathies like hypertrophic cardiomyopathy?
Yes, absolutely. So any of those inherited heart conditions that we've discussed can do qualify for genetic testing. And we can use the National Genomic Test Directory to make sure that they, like they've recently changed the hypertrophic cardiomyopathy testing criteria to being diagnosed at 60, not above, and we can only test hypertrophic cardiomyopathy patients over the age of 60 if we feel that their phenotype has developed definitely before 60 or 60, but also if they have a family history. So if you look at the National Genomic Test Directory, it has the list of all the conditions that we can test and also the testing criteria.
That's a good reminder for everybody, is the National Genomic Test Directory, which is available. You can just type it in your browser and it will come up for you there as well. The next question we have is, what is the link between myocarditis and inherited cardiac conditions?
Okay, so obviously myocarditis is felt to be sort of inflammatory potentially due to viral insult. But it's been found that in around 10 to 15% of cases, there may be an underlying genetic cause. And with the DSP variants that we've discussed today, if there's a recurrence, that can cause a recurrent myocarditis as well. So essentially with myocarditis, it wasn't something that we typically genetically test for historically. However, for recurrent cases, and if you've got any concerns about your patient, then it can be brought to the relevant MDT for discussion about whether it's appropriate to test for them. But as I say, the pickup is around 10 to 15% of cases.
Georgiana, this one is for you again, and it's, if there's a refusal for a postmortem due to cultural or religious beliefs, would there be an opportunity to take a needle biopsy of the heart instead?
No, so we prefer spleen sample, and with the other tissue that we've tried to analyze, the analysis has failed in most of the cases. We were not able to extract DNA from other tissue samples. So we tried to extract DNA from heart muscle, but it's not as rich. The DNA is not as rich as it is in spleen, which is why we do need spleen to be retained. We can always attempt, but it's likely the testing will fail.
Thank you. And Gil, you've got a question there, but I'm not sure what that relates to, and I don't know if it's relating to FH, but you've asked, could it be part of the newborn heel prick test in the future? I don't know if you want to talk, sorry.
Sorry, yeah, I'm just wondering if it might ever be possible for the testing to be done with the heel prick at an earlier stage, or does it they have to be 2 and over for the testing you mentioned that?
It's interesting. There's been various studies, pilot studies and things done on newborns. There was a study done a little while ago where they checked cholesterol level of, I think it was children at a year when they were having their vaccination was it MMR they have at a year? It's been a while, but I think, and they were checking cholesterol levels, and that was found to not be very helpful. And it's probably because levels vary a lot in children. There have been quite a lot of talks from quite a lot of people in the FH world about why FH isn't one of the things we test for on the heel prick, because it is very common. Very common, and so a lot of the things on the heel prick test are not very common. So yeah, there have been discussions around it. There's a study going on at the moment, generation study. Is that right, Phil? I'm talking about, aren't I?
Yeah.
I'm not sure. I don't think FH is on that. Is it, Phil? I can't
Sure, I'd
remember.
have to double check that, but you can check to see the list of conditions that are been looked for, and it has been amended. I don't know if it's been published yet, so they are, I think they're adding or removing some of the conditions they're looking for. But if you go into the Genomics England website and type in generation study, it will give you a list of all the current conditions that are being looked at.
Oh, thank you. Thank you very much.
Okay.
Gail, you had another question for Angela. For a person with FH on statins, if they become pregnant or wish to become pregnant, do they just stop statins for the duration of pregnancy?
Yes, they do. So we do have a lot of discussion around pregnancy, particularly with our youngsters and also in our paediatric when we're transitioning our young women into adult services. They often, will make a face because they haven't thought about having a baby at 18, but there's different research around statins and pregnancy. So it's recognised that we really, if the advice we give is if you're actively trying for a baby, we would recommend that as soon as you're trying, you come off your statin, you remain off your statin during pregnancy and when you're breastfeeding, and then you can go back on them when you've stopped breastfeeding or finished your pregnancy. Cholesterol levels tend to go up quite significantly in pregnancy, so we do normally recommend that women do not have their cholesterol checked, particularly if they've got FH in pregnancy, because it can really alarm them, and it's really just the body's response to growing an extra person, so they're not very helpful lipid levels. There was a study done which suggested that it's probably safe for women to remain on statins till they're found they're pregnant, but because obviously there are no studies on pregnant women taking statins, because we don't do studies on pregnant women, and there's certainly plenty of women have got pregnant on statins and their babies have been fine, but the advice is that you should stop if you're trying to conceive, really.
Right. Okay. Thank you. That's very helpful.
Thanks, Jan. Final question in the chat is from Carlos that says, could FH be related with haemophilia?
No, is the answer. Haemophilia is a different condition and not related to FH, no.
Thank you. So I think that's the questions in the chat. I think my final question to Steph, Angela, and to Georgiana, firstly, thank you so much for your presentations. But what would you want people to remember from today, a month from now?
I'll go first if you like. I'd like to remember that FH is really common, that young people shouldn't have high cholesterol. So if you come across particularly a young person with high cholesterol and a family history, then do think FH, that things like Q risk scores that we use to diagnose people or to assess risk for cardiovascular disease are not helpful in people with FH. They tend to underestimate risk. So if particularly young people with high cholesterol, think FH is my ending.
Thank you.
I'll go next. If you're a clinician within the West Midlands, I want you to remember that this pathway is live. So if you see any patients with or suspected to have an inherited cardiac condition, or someone who has lost a relative suddenly at a young age, please do signpost them to me or the ICC service at the QE.
Steph?
Yes, so any of your cardiac patients, I want you to consider whether they would be appropriate to test, offer genetic testing to. That is historic patients that have been diagnosed for quite a while. They won't have had access to genetic testing, but also to consider the family history of patients as well in your clinical decision making, because that can help inform clinical decision making alongside genetic testing. Thank you.
Thank you so much. So thank you once again. I'm just now going to go through some resources that are available to increase genomics knowledge and awareness. So I just need to try and share my screen again and make sure that that works. If somebody can just let me know whether it is there or not, because my computer doesn't want to work very well. Okay, so I just wanted to highlight a couple of helpful resources to support genomics in practice. And the first is GE Notes. So this gives some short, clear explanations of genomic terms, testing pathways, and clinical guidance. It is an NHS genomics education resource, and it has been designed for healthcare professionals. It's very practical. It's got 2 levels in the clinic and a knowledge hub, and it's organized by specialty. So you can go straight to the cardiology section, and it's also particularly useful for helping you think about when genomics might be relevant, what the next steps are, and when to refer without needing to be a genetics expert. Then there's also a wide range of free genomics training that is available through the NHS education platforms. The Genomics Education Program website has lots of short modules, courses, and learning resources for different roles and different levels of experience. And you can also find genomics content on e-learning for healthcare, which includes bite-sized sessions that really you can complete at your own pace, and the e-learning for health portal, which many of you may already be familiar with. We also have the Genomics Learning Passport, which is designed specifically for nurses. There is one for midwives as well, but this focuses more on building that confidence and understanding over time at your own pace. It helps you see how genomics fits into everyday nursing practice, conversations with patients, and your professional role, and you can add it to your revalidation portfolio. We've designed it to match our revalidation paperwork. But I think these resources are all there to support you, whether you want quick answers in clinic or you want gradual learning to build confidence. The other thing is that if you want to stay connected and learn more about genomic healthcare, the Central and South Genomics team shares updates on events, projects, resources, and research that supports genomics in practice. And so if that's something that you find helpful, you can scan the QR code there to join the mailing list. There's absolutely no obligation, but it's there if you want to keep in touch and hear about opportunities in the future. I think I'm coming to the end, but I just and you're going to have some free time as well, since we're finishing before 2 o'clock. But I just wanted to kind of pause on this idea that really genomics reminds us to look beyond the individual in front of us and to consider the wider family. And that single result can have implications across parents, siblings, children, and future generations. So we really need to think carefully, communicate clearly, and always keep families at the center of care, because it's one test for with many lives can be affected. But when we apply that thinking in practice, I think that that impact can be quite long lasting. So recognizing inherited risk, asking the right questions, and knowing when to involve specialist services really can prevent future cardiac events, sometimes before they happen at all. And I think this is how everyday clinical decisions really contribute to healthier generations over time. So really, I just want to say thank you so much to our speakers today, the fantastic lead nurses that are managing and running these services and supporting our patients, but also thank you to you all for your questions. It's been really, I think it's been a fantastic session. What I do want, I say want,